Today we're going to learn about Spravato. All right. Some of you have worked with Spravato and helped the patients. You've probably never seen it at all in real life. Okay, so it came the perfect time to learn about Spravato. Spravato is really, in my mind, a breakthrough treatment in depression. Because in all of psychiatry, when it comes to pharmaceuticals, we try to address depression with really one mechanism of action for the most part, targeting three primary chemicals. So serotonin, dopamine, norepinephrine. That's when it's all your antidepressants. And then we try to hit it from a different angle by using augmentation strategies. So we may add an antipsychotic, we may go outside the box and throw some lithium in there, or we may add thyroid hormones and things like that. But oftentimes that's not adequate to fix someone's depression. There has not been a new mechanism of treating depression since Prozac. Everything's been a variation of that antidepressant up until about 2019 when Spravato was released to the public and approved by the FDA. So today what I want to do is I want to teach you how to understand Spravato in such a simple way that your middle schooler could get their MD degree, put on a white coat, and treat a patient. That's my goal for you today. Okay. So let's start here. What the heck is Spravato? So Spravato is an FDA-approved treatment for the treatment of treatment-resistant depression. So it has a primary indication of TRD, treatment-resistant depression. It has some secondary indications that people may not know about. One is major depressive disorder with suicidal ideations and intent. Oftentimes we don't get patients into the program for that diagnosis because Spravato is not approved to substitute for standard of care, which is to get those patients to the hospital. So most of the patients receiving Spravato, unless you're in a hospital setting, is for treatment-resistant depression. So to understand that, you got to understand that treatment-resistant depression is just a person that has a clinical depression that's tried and failed 2 antidepressants and didn't get relief. So that's the majority of patients in the psychiatric realm. Right, so y'all been rotating with me. That's pretty much every patient that walks in the door. And if you're a psychiatrist, pretty much every patient has failed at least one antidepressant, oftentimes 3, 4, 5 of them, making most of our patients candidates for Spravato. Now, how does Spravato work? So that's the most important part. It's a novel and different mechanism of action. So I'm teaching you this because you're going to be taking care of my Spravato patients in Myrtle Beach. So you need to be able to explain it to the patients. Here's how I would explain it. I would say, most antidepressants try to change the brain the same way. They try to increase serotonin, dopamine, or norepinephrine, even though that's a minority of the neurotransmitters in the brain. The most abundant neurotransmitters in the brain are GABA, which is the brake, tells the nerve cells not to fire, and glutamate, which is the gas that tells the nerve cells to fire. Esketamine or Spravato, esketamine is generic, works by increasing glutamate in the brain, pressing the gas pedal. It tells the nerve cells to fire. Now, the reason that Spravato seems to work so well is based on this idea that maybe, just maybe, people are not resolving their depressants with antidepressants because it's like driving a car with a parking brake on. So if we think of the antidepressants like gas in the car, if I was to take my car and try to drive down the street with a full tank of gas but I pulled up the parking brake, I'm not going to get the best operations out of that car. I'm probably going to tear the car up, but I'm definitely not going to be able to do my 0 to 60 like I want to. That's because the parking brake's up. We think of the parking brake is kind of analogous to the nerve cells in the brain that's responsible for regulating the firing in the brain that are called interneurons. They also oftentimes have inhibitory activity, or they tell the nerve cells not to fire. And they work like a parking brake. So the way that Spravato works is it blocks the receptors on these interneurons. The primary mechanism of action is what's called an NMDA receptor antagonist. That's a mouthful. All it means is I'm blocking the receptor that's telling the nerve cells to not fire. So when I block the NMDA receptor, it releases the parking brake. And what happens is it indirectly increases glutamate in the brain. It causes a cascade of changes. So what's going to happen is when glutamate is released, the nerve cells are going to fire more. And just like when you lift weights and you tear up the muscles, there are chemical signals that say, hey, build more muscle, right? Well, the same type of mechanism can happen in the brain, where this increased excitation from this increase in glutamate tells the brain, hey, we need more support. We need to grow new connections because we got to work more. It changes the gene expression of the neurons, right? So what happens is there's a release of something called brain-derived neurotropic factor, or BDNF. Think of it like fertilizer for the nerve cells. So we increase this glutamate, the brain responds, it releases this fertilizer, you get increased nerve cell connection, which is responsible for increasing neuroplasticity. What is neuroplasticity? It's just the ability for the brain to change. So what tends to happen when patients are depressed, they get stuck in this rut. They're in this loop of negative thinking. And also, when it comes to your body, if you don't use it, you lose it. So you get into this neural pathways of negativism. I can't do it, I'm not enough, etc., etc. And you reinforce those pathways. And you ain't thinking about other stuff. So those nerve connections receive in other parts of the brain. Now we're telling the brain, you need to be firing. The nerve cells fire more, new connections grow, and it gives the patient an opportunity to kind of break out of that rut. Okay, that's the proposed mechanism of action, how Spravato likely works for a patient. Now, but who exactly is Spravato for? Spravato is for the patient who is ready to try something new. They've exhausted at least 2 antidepressants without relief. Now, an adequate trial of an antidepressant means the medication was pushed to the maximum dose of that medication. And the patient has been on it for an adequate amount of time, which is typically 6 weeks. So if a patient starts at a starting dose and they never go up and they try for 2 months, that's not an adequate trial. A second definition for adequate trial is you tried the antidepressant and you had side effects that prohibited you from going forward. So you took the medicine and it made you suicidal. Okay, that's a failure. Okay. So if a patient had 2 failures, they qualify for Spravato. Okay. Now, who is Spravato not for? So Spravato is not for everybody because there's side effects that can happen with Spravato. Here's the good thing. The side effects of Spravato are transient. That's the most important part about understanding side effects for Spravato. Is that I always tell the patients, it's like you don't have to carry around your side effects with you all the time. That's what patients do with antidepressants. They walk around with this backpack of side effects, and they got weight gain and sexual side effects and all these other things that go along with it. With Spravato, 98.1% resolve within 2 hours. 99.1% resolve within a day of treatment of the side effects that's associated with Spravato. So before I tell you who it's not for, let me list some of the common side effects. One is potential for dissociation. So dissociation is just an alteration of how someone thinks. That can be something as small as just feeling tired, or it can be as extreme as an out-of-body experience. Anything in between is considered dissociation in the studies that led to the approval of Spravato. Increase in blood pressure is common. So patients can have an increase in blood pressure in their systolic and diastolic blood pressure. Therefore, the patients must be monitored in the doctor's office after administration of this medication. Spravato is only available in a very specific program called the REMS program. It's a third party that monitors the administration and monitoring of each patient that receives it. So it's a third party that does that. That way, all patients come to the office, they get treated for 2 hours, they're observed by the doctor's office, and then once they're ready for discharge, they can leave, right? Because of the risk of these side effects. Spravato also has the chance of causing sedation. It can cause some level of respiratory depression, especially with patients who are on multiple brain depressants. So like if you're on benzos and opiates and things like that, it may not be appropriate for patients who are on too many of those medicines. Spravato does have a chance for abuse and misuse because it is a derivative of the medicine ketamine, which has street value and has been abused on the street. Once again, necessitating that REMS program to make sure patients don't have access to this medicine outside of a controlled environment. So you can't just go to CVS and get the medication. Okay. There are other side effects that can happen with Spravato, but I'll talk about that on another video. As to not bog this video down. But the gist of it, the most common things people are going to experience, they're going to have a level of dissociation. Oftentimes that's pleasant for the patient because it disrupts this normal way of thinking for the patient. And it tends to be a relaxing experience. So, especially if you control the environment. We try to control the environment so it's quiet, the temperature is comfortable. We encourage the patient to wear eye masks and hearing protection, usually earplugs and or like earbuds and listen to instrumental music, because the dissociation is a very internal experience. Okay. You can take advantage of this side effect as a potential therapeutic side effect. So with the assistance of counseling, this dissociation experience, oftentimes people have what I call the epiphany moment, where they have revelations about life, about the way they're thinking, about past experiences that they just cannot have because they're stuck in a depressive neural pathway. They can't think differently. They can't think outside the box. So dissociation sometimes allows people to think outside the box, leave them for a moment. And when it's supported by counseling, you can kind of reinforce those ideas into their daily lives. Okay. So, in a nutshell, the patients who should not have Spravato are typically patients who cannot tolerate an increase in their blood pressure. So if they're already hypertensive and it's uncontrolled, they might not be able to tolerate Spravato. So at our clinic, we don't allow patients with a blood pressure greater than 150 milligrams of mercury systolic to start a Spravato treatment. They gotta be below that. Especially because we expect at its highest up to 40 points jump in the systolic. Most patients is 5 to 10 point jump, but it can be up to 40. So if you already started at 150, it may bring you up to 190. Okay, it's not for patients with aneurysmal vascular disease. So patients with AV malformation or any history of intracerebral hemorrhage, that's not for them. Oftentimes restricted for patients with heart attack or myocardial infarction history, unless they get clearance from their cardiologist. Okay, we have to be selective about patients with substance abuse history. And it depends on where they are in the stages of change. So we won't exclude people who have previous history of substance abuse, but they're active in their substance abuse, so it may not be the best treatment for them. Okay. It's not approved for people in pregnancy. So if a patient's pregnant or planning to get pregnant, it's not for them. And also women who have already delivered, they can't breastfeed. By doing Spravato can be found in the breast milk. Okay. Let's see, what else? That's all I can think of right now. So last I want to kind of talk a little bit about like what's the process? Like what is the patient experience when they do Spravato? So Spravato, to get Spravato, you have to be treated only at a REMS certified center. That means that center is certified by the manufacturer, and the REMS program, which was mandated by the FDA, to have certain provisions in the practice to make sure this can be administered safely. Okay, so you can't just go to any clinic and get it. Okay, when patients do this, they go through a medical clearance to make sure they're psychiatrically and physically safe to do it. It's only approved for major depression, so if patients have bipolar depression or schizoaffective disorder or something like that, they can't do Spravato. Okay. After the medical clearance, they'll transition into their treatment after a prior authorization with the insurance. Okay. Insurance covers this. Almost all the insurance covers Spravato, with very few exceptions. It depends on the policy though. Once they've got authorization, the treatment course is they'll do 2 treatments per week for a month. Then they'll do 1 treatment a week for a month. And then they'll transition to long-term maintenance, which typically is once every 2 weeks. Anything beyond once every 2 weeks is not on label, not approved by the FDA. Okay. Some patients can't tolerate once every 2 weeks, they may have to do it once a week. Okay. Now, as far as expectations for results, in the studies, some patients had response in as little as 24 hours. So some patients improved within 24 hours. In fact, the majority of patients did. So it immediately separates from placebo at that time. And at 28 days, the reduction in MADRS, which is like a depression rating scale, was greater than placebo. So usually I tell my patients, let's give it a month. Usually you have a good idea whether it's going to work within a month. If there's no response within a month, typically they're going to be non-responders. The response rate to this I found to be around, the response rate for this I've found to be around 70%. The studies are still about 68%, I want to say. Okay. So 7 out of 10 patients will get a meaningful response from this. Can't think of anything else than that. So 7 out of 10 patients get a meaningful response from Spravato. And that's all I can say about that. Okay. All right, so here's a quick recap. So Spravato is a new FDA-approved treatment that's just a new option to help the patients. It's a nasal spray. It's done in the doctor's office. The side effects are transient. And it's definitely something that can improve the quality of life for our patients. One thing I didn't mention in the main talk is that this is only approved for adjunctive therapy. This is not monotherapy, meaning that you don't just do Spravato by itself. The patients are either on a new antidepressant or they continue on their old antidepressant when they start this. Okay, so that part's important. All right, very good. So I'm gonna stop there, and I'll edit in the outro and the recap. Let me answer your question. I have any questions about Spravato? Because I kind of feel like you two probably got a good feel for Spravato, but you may not. Do you have any questions about Spravato you can think of?
Yeah, well, you just answered one of them, like, what was it by itself? But you said you have to be as an adjunct.
Yes.
So the previous antidepressant or
right.
And then they said about the blood pressure, it has to be less than 150 systolic.
Mm-hmm.
So is that like something that can be controlled and then they can receive the treatment if they get it under control, or it's just a rule out, like, you can't have it?
Right. So a patient can have hypertension and still receive Spravato, so they can get treated and get their blood pressure control, and they can get the treatment. Okay.
Also, the girl that did the testimony today, she said she got hit with a crowbar.
Mm-hmm.
How long ago did she do that? Because she said that she tried ketamine.
Mm-hmm.
Is a TBI contraindicated? No?
No. So traumatic brain injury may not be contraindicated. Depends on the nature of the traumatic brain injury. So if she had a hemorrhagic bleed and she had stroke and things like that from the head injury, then probably not.
Probably.
If you had like the concussive syndrome or something like that, then likely you'd be okay with the traumatic brain injury.
And last one, which it might be stupid, but can they drive after the treatment, or somebody has to drive them?
That is actually a very excellent question. So patients cannot drive after Spravato.
Okay.
Because there is some alteration of senses. Is actually, we tell patients that they can't drive until after they have a restful night's sleep, or 24 hours.
Okay.
So that's one of the treatment barriers for patients, is getting transportation. However, if the patients are vets, they can get VA transportation to and from for the appointments. And our office actually visualizes the patients getting in with their driver.
Okay.
So that way patients don't say, all right, my driver's here, and then walk out and get into their own car, because it's not safe for them, even if they feel back in their normal senses. We also make the patient sign a waiver that they won't drive after their treatment, after every single treatment. Because patients still will try to drive their cars. Like people leave the bar and try to drive their cars. So that's a good point. So just, I don't know, in my opinion, Spravato's been very successful for the patients. Got a question?
How do you objectively classify a response? I know you said
that's good.
70%.
Right. Here's how so what they used in the study was response and remission. Okay. Response would be a 50% reduction on a standardized rating scale. Okay. Remission would be not meeting criteria for depression on the standardized rating scale. Okay. So my expectation is 70% of patients will have a meaningful response within that 70%. A percentage of those patients will reach remission. Right? So let me put that in perspective for you. If if you look at like the STAR-D trials, are you familiar with STAR-D? Okay, you familiar with STAR-D? You familiar with STAR-D? Perfect. This is super important. Was when you know the depression algorithm that people go through. It's like, oh, I'm depressed. Start with counseling, you give them an antidepressant. You work them through the dose range, then it didn't work. What do? You try another antidepressant, typically SSRI. So you might start with SSRI. That fails, you might try another SSRI, or you can try SNRI. If they fail the first two, almost always you're going to try a SNRI or a DNRI. If all three of those fails, then you're going to try another antidepressant plus an augmentation strategy. Why do we do that? We do that because of the STAR-D trial. So the STAR-D trial is one of the largest studies that tried to answer the question, how well the antidepressants actually work? And I want to say, don't quote me on this, I think it was about almost 3,000 patients with their first episode of major depressive disorder. And what they did is they took all of those patients, they put them on citalopram. And they measured how many patients responded, how many patients reached remission. Okay. And don't quote me on these numbers, I gotta look them up again. I can't remember. What is it? I know it looks like this though. I remember the last two. That's why this is my ballpark. 17%. And this is less than 6%. So if we look at the response and remission rates on the first antidepressant trial, I think the remission rate was like 33%, something like that. Then it was like 20-something%. So maybe 20, 25 or something like that. So basically what they did is they tried them on an antidepressant and they said, how many people reach remission? Only about a third of patients. Right? Which is bad. That means 2/3 of patients didn't get better on the first antidepressant. That failed, they put them on the second antidepressant, which was another SSRI. So I think they did SSRI, and then another SSRI, and then they did an SNRI. And then they can basically do any type of combination therapy, et cetera, et cetera. And that's where the algorithm comes from, this study. Right? So what we found was, every time you failed one, your chances of reaching remission went down. And by the time you failed 3, your chance of the fourth one working was less than 6%. And it just kept getting lower and lower for each trial. Okay. The second part of this study that was important to understand was the time to relapse. So what they found for our treatment-resistant population, people that failed 2 antidepressants, the average time to relapse was 3.1 months, which is terrible. Well, that indicates that depression has a high recurrence rate in this population of treatment-resistant patients. Okay, so that's, to me, that I don't like to think about it like statistics and numbers. You got to think about like people, right? Right. You got people walking around. They're going to see a psychiatrist. They're taking their meds. They're coming once a month or once every 3 months, right? They see you. You give them medicine. They say, "Oh, that worked for me." My expectation is 3 months later it's not going to be working for you, based on the average relapse rate of patients. Okay, that's why we see patients for years over time and they ride the roller coaster, because this is a chronic disease. 3.1 months is the relapse time. Here's a great thing about Spravato though. So there's a trial called the Sustain Treat 3 trial. Sustain 3. The purpose of that study was to look at the long-term effects of Spravato, like what happens over time. So this is 6 years. Okay, so if you look at how the patients responded, and this is year 7, I want to say they had about 5,000 patients. A lot of patients. Right? The majority of the patients stayed in the study over 7 years. So what that means is it's very tolerable. It's hard to get people to stay in studies. And naturally, there's a dropout of patients over time, but they retain a large proportion of the patients in the study, Sustain 3. Kind of hinting at how well it works. So basically what it was designed was when Spravato was FDA approved, they used data from 6 different studies. And basically the way the study was designed And I know this is like way more than 10 minutes, but I'm just going to go with it. We're going to go with it. The way the study was designed, it took people with treatment-resistant depression, which is atypical for studies. Because typically when you want to get an FDA approval, you don't want the sickest people. You want the people that's kind of sick, that meet criteria, but not really that sick, because you spend millions and millions of dollars to get an FDA approval. You don't want your study to fail. Or you got to repeat the study. And I'm going to open this window.
Oh, thank you.
It's getting hot.
I thought it was me.
And y'all are getting
I
sleepy.
was feeling the baroreceptor here.
Yeah, I saw you. Saw you guys.
Coffee.
Everybody was like sweating and passing out.
I want like, is it the ketamine?
That's right, yeah.
Getting me
I
hypertensive.
know. I don't want y'all to die here. That'd be embarrassing.
Thank you.
So basically, they took patients who were TRD and put into this study. All of the patients received standard of care in this study, which is important. So you have a patient with depression, you're going to give them antidepressant. If they need to be hospitalized, you're going to put them in the hospital. Okay. So they took patients and they split them into two groups. One group received standard of care. Other group received standard of care plus Spravato. Okay. And the patients were triaged, and what they were looking at was the change in MADRS scores at 24 hours and at 28 days. Second thing that's important about this study is you never look at antidepressants at 24 hours. How long does antidepressant usually take to work?
4 to 6 weeks.
Right, you tell the patient it's going to be 4 to 6 weeks. I'll see you back in a month if they're not, subacute or acute, right? Because we're not expecting it to work. But they had the foresight to look at them at 24 hours, which is very unique. Okay, and then they looked at them again at 28 days, right? I think they basically let a patient with like moderate, severe, and severe levels of depression in the study. Okay, so there was no mild depression in the studies. So in the short-term studies, and I don't have the exact statistics because I'm doing this from memory, is if you look at standard of care, what they saw was that patients' scores went down on the mattress. Okay. What they found with Spravato was patient scores immediately separated at 24 hours, and at the end point, they did better. So I think that the drop in MADRS for Spravato was about 20 points, and the drop for standard of care, I think, was like 15.9 points, which isn't a huge big jump, but the two things that stand out is one, the immediate separation at 24 hours, and two, a drop of 5 to 6 point difference in the MADRS is like separating from severe to mild, from moderate to mild, the mild to remission. So it's impactful for a person's life. When I do my presentation, I always call this my Mo Better slide, because Spravato does more better than traditional care. Because remember that we were giving them care. It wasn't like they were getting a sugar pill, right? They had standard of care. So what they did was all the patients that were responders in these original 6 studies went into that Sustain 3 trial. Where I put that at. Right? So in this Sustain 3 trial, they took all those patients from those 6 studies that had response or remission, and they wanted to see what happened over time. So if this is this first month, it kind of dropped just like we showed in those first 6 studies. But once they reached that level of improvement, the improvement sustained for years, not 3.1 months. That's the most important piece of data about Spravato, is that once patients are stabilized on Spravato, they tend to stay stable. Now, what they do have to keep doing treatment though. They can't just do too much and stop. These patients were typically doing treatment twice a month, or every 2 weeks. That was the most common pattern. That's why that's on the labeling, every 2 weeks. Okay. Sometimes when patients regress, they'll go back to once a week, and typically that's enough to kind of get them stabilized again, and they transition back to twice a month or every other week. All right. So why is this important? This is important because most patients will go take antidepressants, see their counselor, not feel that much better, have a lot of side effects. They'll be functional, but they're not really living. Now there's something they can take that actually will improve their depression and keep them out of the depression hole. It's safe, it's tolerable, the side effects are transient, and the insurance covers it. That's a win-win. So to me, I call that a breakthrough. All right. So that's the gist of Spravato. And everybody should at least try it once if they have treatment-resistant depression. Okay. All right. Any other questions that you think of? Do you feel like you would know who to send for Spravato based on that quick talk? Okay. I'll put this. Who would you send for Spravato based on this talk? If you had a patient you're taking care of, when would you say, all right, when should you talk to your patient about Spravato based on the information I just told you?
After at minimum 2 failed standard of care medications, result of the PHQ greater than, 15 or higher. And if they experience negative side effects with the standard of care immediately, that were drastically not recommendable.
Right. So, I heard you say, any patient that's already failed 2, they still have clear evidence of depression, and or they tried medicines that got side effects that they don't want to tolerate. They should at least have the discussion on Spravato. Alright. Very cool. Alright, so I hope that kind of gave you a good bird's eye view of Spravato. And I hope that you understand that this should be something that should be in your wheelhouse. Whether you, obviously you're going to be working with me, you may do any specialty. But almost every specialty comes in contact with patients with depression. And lots of times they don't know about it, so you got to talk about it. Okay? Alright, there it is.
Hold on. One more question. Now that you mentioned that, what's the age, minimum age for this kind of treatment?
Right. So Spravato is only approved for adults. So it's 18 and above. I'm not aware if they're doing any study in children. I suspect they probably aren't right now.
Okay.
But it's only approved for adults right now. Here's for bonus points. So I mentioned that the mechanism of action is an NMDA receptor antagonist or blocker. What's the only 2 other medications on the market for depression that have that mechanism of action for depression? Eligibility? That's correct. What's the other one?
That's straight thing.
Ketamine. That's correct. I'm gonna put an asterisk here because ketamine is not FDA approved for depression, but it has wide amount of research on it. Eligibility is not approved for treatment-resistant depression. It's only approved for major depressive disorder. So oftentimes we'll use this adjunctively for our patients, kind of during Spravato, because some patients can't sustain that every 2 weeks, and they can't afford transportation, whatever reason they can't come once a week. So we may try eligibility and try to bridge the gap. Okay. Very good. Look at y'all. Y'all learned something with this rotation. Awesome. All right, that's cool. That's good.